This afternoon we'll concentrate on the research, and please, Helen, diabetes technology lessons from diabetes in pregnancy.
Thank you, Dorte. Well, having given all of my last few talks in my spare bedroom, it's now I feel I do need a whiskey to speak to a real live audience. Thank you so much for the invitation. It really is amazing to leave the UK, to leave COVID behind for a short interlude, and to do what we as clinicians and academics do, bounce ideas off each other, learn from each other over coffee, and the small talk that happens in between the lectures. Having said that, the lectures this morning were fantastic and phenomenal, and yeah, a real treat to be here. My first academic meeting was actually the DDA when I arrived, I think in the UK, with a 3 or 4 month old baby. So yeah, very special to be here today. So I'm going to talk a little bit about what are the lessons that we have learned from diabetes technology through our work in looking after pregnant women, with a little bit of a glance to the past and a looking forwards to the future. So these are some data on the first descriptions that I could find. I may well stand corrected, knowing that there are better historians than me in the audience. But for large birth weight babies, and of course prior to the introduction of insulin, as someone said this morning, these mothers and these babies did not survive. But back in 1933, 608 infants of 155 mothers with diabetes were born, and they were described as giant infants. And it was known that in the normal maternity population, about approximately 3% of babies had large birth weight, but in this population it was 7 times higher. And that was followed on by other studies describing rates of large for gestational age of around about 60%. And Martin Noffman, in this beautiful New England Archive paper, has said diabetes is much more unfavorable for the child than the mother. And in this regard, insulin cannot accomplish much. And really, I'm going to share with you some data, and as Dorte has said, my 20 years of hard work, and ask how far have we come from those moments and those original descriptions. Well, this is a celebration, and of course, by far and away the biggest celebration and most important outcome and improvement in the management of diabetes in pregnancy is that the mothers and the babies now predominantly are live born. So the stillbirth rate for women with type 1 diabetes is now roughly 10 per 1,000. It is actually now higher for women with type 2 diabetes than it is for those with type 1. And the neonatal death rate is again broadly similar, around between 7 to 11 per 1,000 pregnancies. And that's not only a huge improvement from the early days of insulin initiation, it's also a dramatic improvement over the past 1 to 2 decades. I think someone mentioned earlier that we should tell women with diabetes to not have sex or not get pregnant. And, that probably has not changed all that much. So these data show what, again, have been shown many, many times in the past, the clear and linear relationship between maternal HbA1c in early pregnancy and rising rates of the serious adverse pregnancy outcomes. And by that, I mean really birth defects, or stillbirths, or neonatal deaths. And it's really when women hit a HbA1c level of around about 7% or 53 millimoles per mole that the risk of these adverse outcomes increases significantly. Of course, the women we see in our pre-pregnancy care clinics are predominantly those at this end of the range, and we have spectacularly, certainly in the UK, I'm not sure in Denmark, failed to engage adequately and provide the sort of care and access to contraception that is essential to prevent unplanned pregnancies in the women who are at highest risk. These are data from our UK population-based study. So this is a large data set. It's a real-time data set. And this is a snapshot of 5 years taken between 2014 and 2018. And what we're doing here is looking to say, who are the mothers who are able to achieve the tight pregnancy glucose targets in that crucial first 40 days of gestation during embryogenesis? And the odds ratio for a woman with type 1 diabetes of achieving a target HbA1c Well, the women who are best able to do that are women aged between 25 and 34 years. And there are just so few factors, so few women who can do that. And the women who predominantly are unable to achieve the pregnancy glucose targets, so those who are at the highest risk of major birth defects, stillbirth or perinatal death, are younger age women, aged 15 to 24 years, and they are predominantly women from the most deprived communities. So these are the quintiles of deprivation, quintile 1 being the least deprived and quintile 5 being the most. And these are independently predicting the maternal HbA1c level. Of course, duration of diabetes, as many of you know, is also really important. And maternal BMI, and this is in type 1 diabetes. Look at the impact of maternal BMI on the achievement of the pregnancy glucose targets. And I think I, like many of you, probably expect there to be a very important relationship for women with type 2 diabetes, but these odds ratios are actually even higher for women with type 1 diabetes. So we have a major problem in that the women that we're able to currently treat to target glycemia in early pregnancy are the small group of women aged 35 to 44 who predominantly are more educated and more affluent. And the vast majority of women from more deprived communities and from higher BMIs, we're not, certainly in the UK, doing a very good job with. The consequence of that is actually the rates of babies that are born at the extreme birth weight end, so either extremely large or extremely small for gestational age, are actually largely unchanged since Nothman and Bix's original descriptions. So in the last 2 years in the UK, the rates of large for gestational age or birth weight above the 90th percentile was 57%, and around about 25% in women with type 2 diabetes. And of course, in women with type 2 diabetes, we're seeing higher rates of small for gestational age babies. And babies at both of these birth weight extremes, of course, being uniquely vulnerable and susceptible to stillbirth and neonatal death. What do we know about the impact of glycemia? I've shown you the impact of maternal obesity and of deprivation, but actually how important is glycemia per se to the development of these complications? Well, for women who are able to achieve their pregnancy glucose targets, before and after 24 weeks, if they're able to achieve their pregnancy glucose targets, the rate of preterm birth is about 30%. For those with a HbA1c above 48 or 6.5%, it's 50%. So the impact of glycemia during pregnancy is still enormous, and it's particularly apparent in the common neonatal complications of preterm birth, large for gestational age, which together really account for almost all of the neonatal intensive care unit admissions. These are data saying, well, is there any point to what we're actually doing, working hard with these women, and have we just actually achieved the best perinatal outcomes in terms of stillbirth and neonatal death? Are we going to be able to get it any better? So in this slide, what I'm showing you is the impact of glycemia during pregnancy after adjustment for the early pregnancy HbA1c. So this is simply down to the antenatal care that we deliver. And these data, I think, are quite important because firstly, they show the stark reality that we now see more perinatal deaths in babies of mothers with type 2 compared to type 1 diabetes. A trend towards more stillbirths, which is now statistically significant in the last couple of years. And we have significantly higher neonatal deaths in the offspring of mothers with type 2 diabetes. But very importantly, the single modifiable risk factor is not maternal BMI here, it is glycemia. So the odds ratio of a baby with a perinatal death is 3 for mothers with above target HbA1c. So actually there is still something we as clinicians and obstetricians can do during pregnancy to further impact the stillbirth and neonatal death rates. And this impact is the impact of even small changes in glycemia is very apparent, both for women with type 1 and in women with type 2 diabetes. We then wanted to look and say, well, which of our clinics are, we call it in the UK, learning from best practice and sharing good practice? And certainly in maternity, we love to learn from what good practice is. So I thought, okay, well, let us look and see if we can firstly identify good practice and work out if there are any particular clinics that are achieving better glucose levels than any other clinics in terms of third trimester HbA1c. So this is a funnel plot. It's adjusted for all the maternal characteristics you would expect. And actually what we found was there is no antenatal clinic. There are 172 clinics in this analysis, and all clinics are struggling to achieve the pregnancy glucose targets after adjusting for maternal characteristics. We are all doing really well with women who are aged in that narrow category of 25 to 35 and who are affluent and educated, but we are all struggling to improve glycemia in women from more disadvantaged backgrounds and from higher BMI categories. And none of us are doing this statistically significantly better than anyone else in the UK. And not surprisingly, the funnel chart is equally tight for large for gestational age birth rates. And it's often intrigued me when I look at papers from colleagues in Denmark or in Canada, and I think, how can it be the rate of large birth weight is largely the same regardless of which country and after you adjust for the different ways in which it's measured? And in fact, over the 80 years since the introduction of insulin, the rate of large birth weight is largely unchanged. So that really is a shortcut to my long journey into diabetes technology. Outside of pregnancy, of course, there are many, many studies, and this is an already long out-of-date slide, but it shows you the evidence for using continuous glucose monitoring, or CGM, in populations with type 1 diabetes who are not pregnant. So these are data from outside of pregnancy, looking both at the impact on HbA1c and on the impact on hypoglycemia. And of course, they're all largely the direction of travel is largely favorable with different slopes. So the aim really of the concept, the CGM trial, which Dorte kindly introduced, was building actually on a trial that happened here in Copenhagen with Elizabeth Mathiasen and her group, of using real-time CGM and using it intermittently. And one of the nice and rare spirits of collaboration, we were able to learn from that trial in real time what the lessons were and then take them forward through to the next diabetes pregnancy trial. And this trial was real-time CGM compared to fingerstick glucose measurements throughout pregnancy in women who are already pregnant or women who are planning a pregnancy. And really the striking difference, we found this teeny tiny, statistically significant, clinically uncertain difference in maternal HbA1c levels of 0.2%. But the gold dust, which we did not recognize, I have to say at the time, was the difference in the time in range. So women with type 1 diabetes who are pregnant were spending around about 50% of their time in range, or 12 hours a day, in early pregnancy. And by late pregnancy, they were spending just 10% higher, 60% time in range. So that's a gain of just over 2.4 hours over the whole gestation of a pregnancy. And women who had access to the real-time CGM had that higher percentage time in range of 68%, so more like 16 hours per day. And of course, the million-dollar question is really, does that mean anything? Is that clinically meaningful, that extra 100 minutes per day? The actual exciting finding, I think, about it was the fact that the effect size, the treatment effect of CGM was actually comparable across all of the antenatal clinics, so across 31 sites. And it was equally applicable to women using insulin pens and insulin pumps. But of course, the important thing was, did it really have any impact on the neonatal outcomes? And I should say the trial was not powered. It was powered for maternal glycemia, not for neonatal health outcomes. So after finding the fairly modest and kind of disappointing impact of a 0.2% change in hemoglobin A1C. We went on to look at the neonatal outcomes only after actually quite an argument with the statisticians who said we should stop. We did go ahead and look, and actually we found that we only needed to treat 6 mothers with real-time CGM through pregnancy to prevent 1 large birth weight or 1 neonatal intensive care unit admissions, and 8 mothers to prevent 1 neonatal hypoglycemia. Now, once we found that, we thought, wow, we have hit the gold dust, and this is going to change the management of type 1 diabetes in pregnancy. But actually, few, if any, people were convinced or even all that interested. And we didn't get to change those nice guidelines overnight, unfortunately. What we had to do is I had to go and learn a little bit about health economics, about which I knew absolutely nothing. I was just about able to calculate that the cost of finger sticks throughout a pregnancy is around about £600, and the cost of CGM, or continuous glucose monitoring, is £1,800, so it costs 3 times more. But actually, what turned out to be the most interesting bit of the paper in many ways was that both the numbers of babies admitted to the neonatal intensive care unit and the length of time they stayed there when they were admitted was significantly reduced. And it was nothing to do with the clinical benefits. It was the economic benefit that persuaded the NICE guideline committee that, as one of their advisors said, that they couldn't afford not to fund CGM because this was going to save money for a publicly funded healthcare system. So late last year, the NICE guidelines were updated to offer continuous glucose monitoring, which is the real-time CGM, to all pregnant women with type 1 diabetes, in the hope that that would help more of them to achieve those tight pregnancy glucose targets. We then went on to try and learn a little bit more about this whole phenomenon, which was relatively new at the time, of time in range. And of course, most of us for many years have worked with HbA1c as our surrogate marker of maternal glycemia. And suddenly we're having to learn about all of these time in range, time above range. And certainly me and we wanted to call them time in target, time above target. But we were told by various international consensus panels that calling them TIT and TUT and TAT was not going to cut it. So they're now time in range, time above range, time below range. I still kind of like TIT, TAT, TUT. And these are now the kind of targets that we're aiming for that I think everyone will be well familiar with. But actually listening to the talk earlier this morning about Koch and being the pioneer of visual thinking, I love how he lay there visualizing the experiments overnight. And it made me think, really, what is it we're doing with CGM? I don't think it's anything fancy about all these different markers and all of the metrics and the whistles and bells. It's actually just a visual way of thinking about the management of diabetes that's much more intuitive for people with diabetes. So what we learned was that women who went on to have a large birth weight baby spent significantly more time, as you might expect, with glucose levels in the higher range, and that most of that was in the daytime, with clear peaks after breakfast, after lunch, after dinner. And actually, it's about problem solving. Most of the management of diabetes is not rocket science, and you don't probably have to be as clever as some of the early Danish pioneers. But it's about sitting down and problem solving together with patients. Whereas in the past, I think patients may have come to us for the answers or the insulin dose. And what CGM has done in my clinical practice is it's meant that I don't any longer have all of the answers, and we sit and we problem solve together. We look at these profiles and say, okay, so it is above target. Is this related to hyperemesis and vomiting? Is it stress or anxiety? Is it the choice of food? Is it the insulin dosing, the insulin time, the physical activity? And you begin to appreciate that it's, of course, any one or all of those factors and many others that are not included. And chances are they're all playing some part. We have, and I have for many years I've locked myself in a clinical research laboratory and laboriously documented the insulin pharmacokinetics of measuring the PK of insulins at different gestational ages. And we have long advocated that we should encourage patients to pre-bolus, to bolus a little bit earlier. And I have lots of these sorts of posters around in my office. And they made little or no difference because, of course, in your real life, that is a hard thing to do. But one of the things I think CGM has done, having that visual problem-solving tool, is it has shown people with their own eyes the impact of bolusing exactly as they eat or a little bit earlier. And that opportunity, we saw the slide earlier of someone with their hot water bottle speeding up insulin absorption. I still have pregnant women who will give their insulin 20 or 30 minutes, who will put a hot water bottle on their leg, and who will try and exercise afterwards, doing whatever it takes to speed up the insulin absorption. And that's across all of the so-called fast-acting insulins. The other thing we have learned, and most of this comes from literature outside of pregnancy, is that there is a difference in these newer, flashier, real-time CGMs and the older historical ones that we began using, so the so-called masked or blinded CGMs. And we know with the new ones that you have to wear them as much as possible, you have to look at them. They are awesome compared to finger sticks in American words, but they're actually absolutely not perfect. The alarms are super annoying, but they can be turned off. And of course, people shouldn't set alarms unless they're going to plan to make some action on them. So I try to work out, the art and the science of medicine is working out for the particular person in front of you, whether there's someone who's going to be very responsive, in which case they're going to see these high glucose peaks, and then they're going to develop what we all see, bolus rage. They're worried about their baby. They'll give massive doses of insulin too late and then have problems with hypoglycemia. So we have to really try and support people to get this right balance of using all of this data in a visual way to problem solve, and also get this right balance of being responsive versus being reflective. And for me, it's probably maybe a 50-50 split, that a lot of it you do. Of course, you've got to be responsive, instantly responsive to hypoglycemia. But I think for hyperglycemia, probably being reflective is going to be overall more important. The other thing CGM has given us is this new language in terms of our time in range targets. And we know from a recent qualitative paper of over 3,500 people with type 1 diabetes that they ranked time in range only second after food in terms of the impact that it has on managing the diabetes daily. And actually, when using this in our own clinical practice, we can use it from week to week. Using HbA1c, someone has to work pretty hard at the diabetes day in, day out, night in, night out, for 2 to 3 months to see any change. With CGM, someone can make a change and within 1 week see the impact of that change for themselves. And I think that's one of the really powerful positive feedbacks of using this data visually to problem solve. Now, this was the days when we had a grown-up prime minister in the UK. I won't comment on the other person. The grown-up, and also who happens to be the woman here, you might notice many of you, she's wearing a Freestyle Libre or what we would call a flash or an intermittently scanned glucose monitor. And one of the things about this device is it's a little bit like Ryanair to travel. It has revolutionized and democratized the use of CGM, which hitherto was too cumbersome, too expensive, and just not applicable for widespread use. So in the UK, the rollout was supported, I think in part because of Theresa May and her experiences developing type 1 diabetes. So we now have 50% of the UK adult population with type 1 diabetes who are using flash glucose monitoring. And importantly, it does have a CE mark for pregnancy, which not many devices do. So increasingly, we see data looking at the real-world use. And one of as an academic clinician, I'm hoping that one day the tide will turn back, but it does feel like there's been a real swing towards real-world evidence, which is, of course, important, but it shouldn't replace randomized controlled trials. It's certainly not in my biased opinion, having taken decades off my life running some of them, but these are the data from a Swedish study. We're using a real-time CGM and a flash CGM. Now, this is an observational study. The women using real-time CGM had a longer duration of type 1 diabetes, and more of them used insulin pumps. So this is not a randomized controlled trial. Many people looked at these data and said, well, this is the proof that CGM and flash is the same. There's no difference between the two of them. That's, of course, it's a bit of a fake news story. What strikes me about these data is that all pregnant women improve their time in range in early pregnancy, a massive 10% increase. As soon as they get that positive pregnancy test, they really shift up a gear in terms of diabetes management. And then we and they work really hard from 10 to 12 weeks gestation, but seemingly to no effect until they hit the 3rd trimester. My obstetric colleagues show them their growth scan with their large birthweight babies, and then suddenly there's a behavioural change that's almost similar to that in the 1st trimester. But in many cases, it's too late and inadequate to prevent the consequences of that prolonged fetal hyperinsulinemia for many weeks during pregnancy. This is a recently reported Danish study from Elizabeth Mathiasen's group, asking the very simple but very, very critically important question: is there any difference between this flash or the real-time CGM? Because if these two devices are comparable, then of course we should use the most user-friendly, the cheapest device, and make it applicable and available to as many women as possible. As in many things in life, you do get what you pay for. And these data did not support that the devices were comparable and that they can be used interchangeably. So certainly for me, when I speak about CGM, I mean real-time CGM. If I talk about intermittent, then I call it flash or intermittent for clarity. This is just it's a small little study, and it's a very specialist study. This is a very good an engineering colleague of mine from the US, Ayal Dasu, and it's a little study across using what many of us would consider to be the gold standard CGM device. I'm not sure if I'm allowed to name it or not. And women who are on insulin pump. And this is a uniquely well-controlled population of women with type 1 diabetes entering pregnancy with HbA1c levels of 6.6%. They're having their care with the best available CGM device, and they're also on insulin pump therapy. So in terms of technology, it doesn't get much better. And as you might expect, they start out in pregnancy with a slightly higher time in range, 60%. But then what do we actually do with them the whole way through the pregnancy? Very little or nothing. Again, really no change in the time in range right until late gestation. And again, I think maybe the obstetricians are more effective with their large scans than we diabetes clinicians. So that makes me wonder, actually, how far can we go with our current CGM and insulin pump devices? And, we carry our phones. Our phones are everywhere with us. Isn't there a simpler way to make the implementation, particularly the implementation of pump therapy, more accessible, more available, easier for patients and easier for clinicians? So over the last 10 or more years, I've been working and enjoying that interdisciplinary collaboration with people who work outside of your field, working with Roman Havorka, who really is a pioneer, and developing algorithms, closed-loop algorithms that are suitable and suitable for use during pregnancy. And this was our first study. It's a very little study of 12 or 16 women. It's a randomized crossover. So women had used the closed-loop system for 4 weeks. They had a washout for 1 to 2 weeks, and then they used their sensor, CGM sensor and insulin pump, which we call open loop. And of course, the difference is quite apparent. So women using closed loop have exactly the same glycemic control through the daytime. The impact of bedtime lasts a few hours through the night. But the real difference here is that for 8 hours overnight, the automated insulin delivery is adjusting basal insulin while women are sleeping. So they start the day with glucose levels in the target range. that was kind of the headline from this paper. And of course, it's always, I won't lie, it's always exciting to get a paper in the New England Journal of Medicine. That was fantastic. But actually, the really more valuable data maybe were from what happened after the randomized crossover. And rather surprisingly, and the numbers are small and it's observational and has all the caveats that come with that, but actually this group of women were able, in fact, what actually happened was the women themselves got together on a social media network platform and said their interpretation of the patient information leaflet was at the end of the study they could use the devices as they wished. And we intended that to mean that some would use their pump and some would use the CGM. But they took it to mean that they would use the closed loop. They also took it to mean that they wouldn't just use it overnight, that they would use it day and night. And then they collaborated without our knowledge and got a small group of 4 of them who used it day and night, who didn't come to clinic for a few weeks. So we had 1 or 2 patients not show up, and you think that's okay. And then we had 3 or 4 women miss their appointments of these highly motivated women who'd been in the study. And then we start to get worried. And I think, oh my goodness, something has happened to them. Actually, we find because they knew they were using it day and night, they didn't want to tell us until they had some data themselves. And they together got their data, which was off license, unknown to me, unknown to ethics and the MHRA. But it was proof of principle that took us almost overnight from using nighttime or overnight closed loop to using day and night. And then by the time we'd notified all of the various authorities, in a way it was too late and the women were able to continue using it through pregnancy. So a huge learning curve, and thankfully with a good ending. The study, in my mind, that probably deserved to get into the New England Journal but didn't, was actually a smaller second study, which is not, well known or anything. But this is actually the more impressive of the 2, because this was a group of women, half of whom had above target HbA1cs. So the mean A1C at pregnancy booking was 8% or 64. Half of them using pumps and half of them using MDI. So a more typical clinical cohort. And then this time, with full regulatory approval, they were allowed to use the closed-loop system day and night. And they were also able to achieve that pregnancy glucose target and achieve 70% of the time in range, albeit in small numbers and non-randomized, but through pregnancy and beyond, actually. And rather interestingly, in the qualitative research that accompanied the work, the women who achieved a very high time in range hated the system and would never want to wear it again. And the women who thought this was really transformative, best thing since sliced bread, ran much higher glucose levels, but actually really benefited from their quality of life and the diabetes burden reduction. What many women went on to say was that actually it was great having it in pregnancy, and of course, they wanted the best outcomes for their baby. But the really important thing was when they went into hospital, particularly on a busy obstetric ward where no one knows anything about managing diabetes, but they're very skilled in delivering babies, suddenly they were going to have the diabetes management taken off them. Now, this time we were smart enough to know the women might hatch a plan, so we did have the approval for them to continue to use their devices through labour, spontaneous vaginal deliveries, through emergency caesarean sections, and through one unanticipated event whereby one woman had an ovarian cyst which bled during her surgery. And the anaesthetist, in a panic, didn't really know what to do, but asked her partner, her birth partner, to scrub in to manage her closed-loop system. And we think she's probably the first person in the world who had used closed-loop through an ovarian cystectomy, which did also involve a lot of regulatory apologies thereafter, but the outcome was good and the intention was not ours. So currently the devices are much better. The studies that we run on, that on the data I've presented to you, the devices we use nowadays are just, it's unimaginable. The burden of the early phase devices, the sensors we use, the insulin pumps, and more importantly, actually, the connectivity between devices in terms of their communicating more seamlessly in a more user-friendly way. So we do have some adequately powered randomized trials in pregnancy. But actually, there is no closed loop system, there is no CGM device that is going to be able to overcome what we heard earlier, the deficiencies in the absorption of insulin, the physiological challenges of pregnancy, and the fact that really what actually determines glycemia is probably 90% of it is the choices of food made from the fridge. And maybe a much smaller percentage of it is the adjustment of insulin and impact of physical activity. As part of one of our secondary analysis in the concept study, we thought it might be interesting and important to assess maternal dietary intake. And these were women who were pregnant, highly motivated, took part in a randomized controlled trial, and were willing to keep food diaries. And the food diaries that they returned to us, which we didn't see during the trial, they went to a research dietitian, revealed to us that although the average daily intake of carbohydrate was around 180 grams per day, 90 grams, so 50% of daily carbohydrate intake in motivated women taking part in a trial was from what the ADA politely call non-recommended, and you and I would call junk food. There is no system, no CGM, no insulin, however fast, and no closed-loop system that can match insulin to this sort of dietary intake. And this is the challenge, and it's particularly a challenge for women from more disadvantaged communities and women from higher BMIs. But I don't want to end on a bad note. When I was sitting this morning, I got this very lovely message from one of our women with type 1 diabetes who has had problems with fertility for 6 years. She's been coming along to our pre-pregnancy clinic for 6 years. And she says after 6 years of crazy hard work and then 246 days of pregnancy, over which time she took 17,000 units of insulin, she did maintain 70% time in range and 216 jabs. And I have to say, when I glanced at the photo, I thought, oh, her baby's on the beach. But actually, these are the insulin pump catheters and the CGMs that she collected through pregnancy. A real reminder that diabetes is about patience, and type 1 diabetes is hard work. It's hard work with technology. It's just humbling, isn't it, when you think of the efforts she's had to go to and what she's had to do to deliver this lovely little girl. So, thank you.
So thank you for a really inspiring lecture. So we are talking primarily about the pump systems. Can you comment on what's your position and your interest in the connected pens that we are currently trying to bring out, and do you have a comment on what is in them of use and what is not in them, and what should be there preferably in the future?
Yeah, I sometimes wonder whether there's a huge benefit for insulin pumps in reducing severe hypoglycemias. I won't deny that. But in my own practice, I sometimes wonder if some of the benefit is having accurate insulin dosing information. So I think the benefit of having the smart pens is that we'll have that accurate insulin dosing information for women who are not using pumps. So I see a huge role for them in conjunction with multiple daily injections in type 1 diabetes, and also, of course, in the management of type 2 diabetes in pregnancy. And I'm sure outside of pregnancy, but pregnancy is where I think that actually they could be really important.
Merete?
Hello, thank you for a very nice talk. I was just wondering, the results that showed that the RT-CGM was significantly better than the IS-CGM, how much of that do you think is due to the first one having alarms?
I definitely didn't say it was significantly better because there's no randomized control trial comparing the two. And of course, the current version of intermittently scanned CGM or flash does have alarms. For me, the issue for people with type 1 diabetes is fear and risk of hypoglycemia. So personally, if my life depends on insulin delivery, what I want is the glucose sensor with the best accuracy in the lower range. And the worry during pregnancy in particular, if you're overcalling the lows, in a population whereby 50% of people are already snacking on junk food and women think they're running low, it's probably human nature to eat some additional food. So for me, I think it's really important that you have accurate warnings for hypoglycemia that don't overcall it, because otherwise people truly at risk might start to ignore it. And then for people who are less at risk of hypoglycemia, if we tell them they're hypo when they're not, they just might eat more, and maybe that's not such a good thing.
Well, thank you for an excellent talk. I was just wondering how much research have been into the drivers of these nutritional choices. You said maybe hypoglycemia is the driver, but is it other restrictive diets they are trying to have during pregnancy that makes them hungry all the time, or what is it that makes them take these choices? Do we know that?
Yeah, I mean, that's the million-dollar question, isn't it? Why? Certainly in the UK, I can't comment in other countries, but the intake of what we now call highly processed food is predominantly amongst those from more deprived communities. So I think there's a huge impact of socioeconomic deprivation and education. As to, I'm not a psychologist, so I can't talk on the, we know that there's emotional eating, and then there is I don't remember the proper term, but it's what we all did at lunchtime: see food, eat food. It looks good, so I'll have some of it. And of course, pregnancy is a time of heightened emotion, so it's understandable that there will be some element of emotional eating. But I think that is an area that really is underexplored, under-researched. And I found it completely staggering that women were willing. If I ate what they ate, there's no way I'd be telling the truth on my food diary. And it does make me worry that it might be even more alarming.
Yes, I think we have a couple of questions on the screen here, Helen. Just the top
we do have questions, but they're not questions I can answer.
Yeah, the top one you can.
The top one I can
I'm very
answer.
sure.
So do you also offer CGM to women with gestational diabetes? I mean, it's an excellent question, but of course we don't have randomized data in women with gestational diabetes. In my mind, CGM is a tool around dietary education. It's a tool that helps people understand the relationships between what they eat and their glucose levels. If it were affordable, I suspect it's potentially likely to be beneficial. But I think if we practice evidence-based medicine, and certainly if we look at some of the recent New England Journal publications in large groups of women with gestational diabetes, their pregnancy outcomes are now comparable to that in the background maternity population. So with, as we heard earlier, a world in which some people have no insulin, I'm not sure that I can hand on heart say that women with gestational diabetes are going to need these sorts of technologies.
Okay, any more from... There's another question from the audience.
Do you have any experience with the commercially available hybrid closed-loop systems in pregnancy?
Yes, an absolutely painful experience. Our trial was recruiting really well until those devices came along. All technology is good. We have, I think at the moment, I have 3 or 4 women who are using the DIY looping systems. The Medtronic 780 is, again, infinitely superior to anything we've seen from that company before. And the Tandem is so user-friendly and is using the Dexcom sensor. So I think any of the automated systems are going to make basal insulin delivery more precise, more personalized, and more finely tuned. None of them by themselves are going to be able to deal with the issues around prandial insulin and postprandial hypoglycemia.
So thank you, Helen. I think we have to close the session. I want to. You have two on the chat here. Okay.
Okay, whiskey time.
I thought it was up there. It's this, thank you very much. In relation to pumps, what is your current split of pumps to MDI for women with type 1 diabetes?
In my own clinic, it's exactly 50-50. And in our large nationwide data, it's, I think, it was 35%, and I think it's now close to 40%, so almost half and half.
The second part of the question, are you using closed loop in those women who are using pumps? And you talked about
that. Yeah, I mean, for me, I think pump management is so difficult and so complicated. And if you happen to live with someone like one of those Dutch pioneers who's a mathematician and you're highly regulated, educated, and you can probably manage a pump quite well. For the majority of people, and I think the majority of clinicians, I think automated insulin delivery is going to replace kind of standalone pumps. I mean, the algorithm, the app you carry on your phone is not expensive. The expensive bit of the kit is not the pump hardware, of course, it's the catheters and infusion sets and the CGM. So if you're already paying for CGM and pump consumables, it's a no-brainer to not use an app so that you use that pump more effectively.
Okay. And the last comment is from Andrew Hattersley, who will be one of the next speakers. Lovely lecture, Helen. We see great advances when patients have CGM in pregnancy, but find it very hard when it has to stop out of pregnancy due to lack of funding. And how do you manage this? It's a burning question.
Oh, thank you, Andrew. And I miss you. I wish you were here. Yeah, we manage it by patient nudge power. So when we began, we got funding from NHS England to provide CGM for use during pregnancy with the absolute promise that if they gave that, we wouldn't ask for more. So, and I felt I couldn't, but actually the women did. So we now have 12 months of use. So most women get their kind of 6-7 months in pregnancy and at least that crucial first 5-6 months thereafter. So not having to take it away instantly at the end of pregnancy, which is wrong and immoral.
Thank you. And thank you again, Helen.